Question to Dr. Kirstein. The rules, gentlemen, as I said before, that if a question is addressed to a particular person, we start with that, and then we allow the others to add their point. So first question to Dr. Kirstein. Your cases had 28 teeth. How does your model change when A cuspid is an implant? Let's start with that.
You can use a lateral incisor. You can use the first premolar, although it's less than desirable. And sometimes we'll use the canine implant as part of the early guidance, although it's ill-advised, at least in theory, because it puts lateral stress on the canine. So if I can use the lateral and the central, actually Clayton showed yesterday a number of cases where he transitioned across the front. That's what we would try to do. Same idea, because the front teeth don't have the neural input. So you can use centrals, laterals, or canines. Now, if the lateral is out of contact, and there isn't a way to use it, you could bond in contact, or you can use the mesial, the first premolar. The premolars create muscle activity, but not as much. They don't have the amount of periodontal ligament receptors. They don't have the root surface volume, and so they fire the muscle slightly less than the molars. So if needed, you can use the first premolar.
Does anyone want to add anything to that? There's one dentist there who might want to. Hello?
Yeah. On the, I think on the download on the internet, I think some of the people were asking about my slides, and on there I didn't show, I skipped over one slide, but on there is an apparent, there are apparent fibers in the bicuspids, first and second premolars that are higher based on the studies that were shown. You can see that on the mesial facial inclines that Dr. Kirsten showed. That would confirm some of that evidence that the mesofacial and buccal areas on the first, second bicuspid and the mesobuccal of the first molars are more sensitive. So by clearing out those mesofacial inclines are very important to create that more balanced response and take out the forces there.
Okay, thank you, Dr. Jen. There are multiple scenarios for Dr. Kirstein's question. So the second part is, so how does your model change when, we've done the first one, a cuspid is an implant. The second situation would be when the cuspid is missing. Example of palatal impaction and not restored and space is closed.
Space is closed.
Space is closed, no cuspid.
Well, again, the goal would be to use some combination of centrals and laterals to control the guides. Avoid the premolar if possible, although if it's in the canine space, as we move forward, that may be difficult. At some point, the premolar would become involved in the guides as the person moves far enough laterally. So, again, the same idea, using centrals and laterals in lieu of the canine, and you'll have the same physiologic response.
I think I'm with Robert. The key to, regardless of implants or whatever restorative, is to minimize the force vectors as the jaw is functioning, because you do want the muscles to function in harmonious balance with however the jaw is moving. And as the jaw wants to move forward, you're going to find that the force vectors of the master muscles and temporals also change, not just in the clench mode, but in the expressive movements. So as the jaw is moving expressively in the canine rise or disclusion, you're going to see that the muscle EMGs also change. And the amazing thing is nature designed it to create proper disclusion mechanically when you go that way, although we don't necessarily choose that way, but it is set up that way for proprioceptive response to reactions.
Okay, their third example would be, what about partially edentulous arches? This is obviously from Canadian. Only has 1/6, 2/3, and 2/4. 1/6. Upper right first molar, left cuspid, and first bicuspid.
And I have treated a number of patients who are partially edentulous. As long as there is some molar engagement, they have the potential for higher muscle firing. So you'd have to create a restored situation where you could prosthetically, for example, use a partial denture and exclude from using partial denture teeth, which certainly have no neuromuscular tie. And I've actually done that years ago. I had a patient who had no canine and had second molars that were in play. And so it doesn't matter how many teeth, it's just a function of which teeth are and how long. So you have one molar on the right side that's engaged in working and balancing prolonged exclusion. You need to create a mechanism to separate that in some anterior tooth component. Removable prosthodontics. I don't think in this era we probably do implant prosthodontics, and we have to splint the implants together in order to deal with the lateral stress. And all of us who have cases where you're missing lots of corner teeth and have to restore with implants, it's almost impossible not to use the implants to control the guides. It's virtually impossible. So, you know, splinting them helps you keep them from splaying and spreading, and they will. I have had a case many years ago, a patient had implants that came to me with an implant bridge right and an implant bridge left, both full arch reconstruction, but split in the middle, and they were spread, right? They weren't, so even splitting them, if the lateral stress is too great, it'll move the implant prosthesis out. So it's not an ideal situation with a pain patient. You can probably start with something removable, and create the exclusion, get them out of symptoms, and then discuss the optimal way to restore them in some way.
Okay, and the final part of this option question, is there a recommendation for implant overdentures and implant full arch bridges? Implant retained dentition, obviously. Is there a recommendation for implant overdentures and implant full arches?
Is this directed to me?
Yes, sir, same question, yeah.
When you have complete dentures, the problems for the pain patient are usually AP and vertical dimension, more so than obviously tooth contacts creating excess muscle fiber. So you have to treat them in a way that establishes a jaw position that minimizes their muscular discomfort. It's a very different problem. When it comes to overdentures, this is a very interesting subject with using the T-scan. Wherever there is an over component, whether it be a bar, a ball, or an attachment mechanism to a single implant, the forces all concentrate there. There's no movement in that area. So there's massive pressure building in those areas and can create physical discomfort. Not muscular discomfort of the type we're talking about, but bite discomfort. So digital occlusion helps you with that. It helps you to see where the extreme overload is, and you can moderate it until it's normalized. But it's never, ever reduced to the rest of the denture, because there's always a lack of movement where the rigid elements are. So you have force concentrations that are greater there. And that's one of the reasons those prostheses can become uncomfortable, and also the attachment mechanisms can wear very quickly. With the full arch implant patient, what we try to do is move the center of force into the middle of the prosthesis, sort of like I showed you on one of the cases, the early case, Dennis Marango's case, moving the center of force into the middle of the occlusion. We would do that with a full arch implant case. We do that with a full arch set of crown and bridge, full arch, anything that's a full arch. You do it on an orthotic device that's full arch. And the goal of that is to not have shear stress. So the center of force is in the middle of the distribution of teeth. You're not having any shear from closure. And then laterally, this is the part that is not yet well understood. There is no real way to not have some form of anterior guidance and succeed with implant dentistry, because when you have group function, you have friction and drag, and that creates shear. So you really can't create a posterior group function on a full arch implant prosthesis to try to distribute stress over many teeth. That just increases friction and drag, and then you worsen the shear. So I would try, and of course this is up for discussion, but my goal would be to use, again, centrals and laterals and canines on the implant prosthesis to remove the shear from the back teeth of the implant prosthesis and create measurable immediate exclusion. It certainly puts the corner of the prosthesis under shear. So that's why it has to be splinted in one piece, so that the left side counterbalances the right shear, and the right side counterbalances the left shear. And nobody really knows yet what the right design is for those kinds of prostheses. But minimizing friction and shear and drag is the goal.
Okay. Thank you, gentlemen. That was very well done. I think we've covered every possible scenario there. The next question looks like it's addressed to Dr. Bernardo, but I'm quite certain that Dr. Tunks would want to add something as well. Dr. Bernardo, please discuss how the use of home sleep studies may help we dentists in evaluating sleep bruxism.
Is that not working? I can't seem to make this one work.
We're good, right?
The about 8% of the population will grind their teeth during sleep or have sleep bruxism. And for a dentist, the use of a metabite then to measure EMG activity at night can then help identify that sleep bruxism, particularly during the daytime if you see abfractions and wear and tear in the teeth. So what you'll often see at night is bruxism identified or associated with respiratory disturbances. It's not to say that sleep apnea and sleep disordered breathing causes all bruxism, but there certainly is some association. Some research has suggested that up to perhaps 25% of sleep bruxism is associated with sleep disordered breathing. So there's a sizable percentage of the general population that exhibits sleep bruxism, and there's a considerable portion of those people that have bruxism associated with sleep disordered breathing. So some people are of the belief that it's bruxism seen at night can be kind of the body's attempt to open the airway, and then by using a product like the metabite, a dentist can then practice within the scope of dentistry in an area that cannot be argued to be outside the scope. So sometimes you'll encounter physicians who might suggest that sleep is not within the purview of dentistry. However, as we've heard from Dr. Levine, anytime you stick something in the mouth, you can affect tongue space and you can affect the airway. So by examining bruxism, a dentist can certainly say, I'm looking at this area, this is certainly within the scope of dentistry, and if you identify severe sleep apnea, for example, then that person could be referred on to a sleep laboratory and a sleep doctor for CPAP therapy.
Dr. Thomas, do you want to?
I have nothing to add other than to say that I do think that dealing with questions of sleep apnea is very much within the competency of dentistry, and I think it should be recognized as.
Thank you. This looks like a question addressed to anyone, presumably to the sleep folks. How does amitriptyline or gabapentin affect sleep stages, and how?
Not a question.
Gabapentin, for the most part, is not a hypnotic. In my experience, it helps some people who have widespread pain, particularly by working on the central mechanisms of widespread pain, and there's less sleep disruption because of it. Amitriptyline is an extremely complex and dirty drug. I'm not saying that it doesn't have its utility, but it hits so many different transmitter systems, has so many side effects that it's very difficult to take it all apart. The anticholinergic part lowers brain arousal, and it tends to carry on even for 3 days after the dose in lowering brain arousal and reducing cognitive function. The serotonergic part may promote slow wave sleep, but it may also inhibit dreaming sleep. And there may be significant dream rebound, REM rebound in people who take the amitriptyline, where they begin to get sleep interruptions because the REM is trying to rebound. So it should be considered hypnotic in that sense. And there are no drugs that I know of that are used for sleep that aren't in some way toxic to the mechanisms of sleep.
Thank you. Dr. Kirstein, when the bite is balanced, how long would you see it get, how long would it take to get out of balance, and why, such as in your case?
Well, yes, such as in my mouth. What we find over time is that the general force pattern measured is similar to how it is left, which means whether treated or not, it takes on a common consistency. That is the nature of the way the teeth lie in the alveolus and the way the muscles operate. So if it's unbalanced today, it'll be unbalanced in 5 years, it'll be unbalanced in 10 years. And if it's balanced, it'll be close to being balanced, but it won't be equal pressures on every tooth. Some teeth will take more pressure than they should as time evolves. The way the teeth sort of settle into the socket, especially after treatment day, start out like at the end of a treatment day, the forces are all moderated and they're kind of low. And all those pinks and yellows will be removed to greens and moderate greens. So you basically have leveled the forces. A week later, there'll be a tooth or two that strikes forcefully, and maybe 70% of the way into the bite it will rise to more pressure, as opposed to, let's say, 30% of the way, which is a damaging early force pressure rise. So over time, the bite becomes different and similar yet. In other words, it assumes a homeostatic environment. Some of the teeth will take too much force, maybe not deleteriously, but they will take too much force. And the center of force position also tends to move backwards over time. It finishes in the middle of the arch, in the middle of the distribution of teeth. As we measure people long term, we see when they come back, 6-month recall, a year later, a year and a half later, 2 years later, the center of forces move more posterior. As the back teeth rise up in the socket, a little shift due to the fluid environment, and because of the muscle angle, they tend to take on more force. You can't really stop that. You could go in and keep treating it, but I think that's a little extreme. We only retreat if the symptoms appear again. And usually what happens is a person would say something like, I give an example, someone has a bad thing going on in their lives. Like I have a patient recently, not a bad thing, she was planning a wedding for her daughter, and it was getting closer and closer to the day, and she's like trying to get it all done, and she's getting all freaked out. And so her symptoms returned, she'd wake up with a stiff jaw a little bit, and she'd have a headache here and there. So we go in and refine it for her. But we won't necessarily just randomly treat it because there seems to be a slight change in the force pattern. Having said that, the last part of the answer is, on recall, if I'm doing restorative dentistry, like the cases that Clayton showed yesterday, and I will recall those patients, and we'll check them with the T-scan at a recall, and if there is a change where there's a rise in extreme force on one of the teeth, we'll go in and moderate it right then and there, because that prolongs the life of the restoration. Cyclic loading is what causes things to crack and break and fail. So if I have a fancy prosthesis, I'm going to check it every recall, and sure enough, we find contacts that become problematic over time, and that we can mitigate at right then and there in the hygiene room, basically, and that saves the prosthesis. I can't say that I haven't had any long-term breakage. Of course, dentistry, people say they only break their teeth on bread and donuts, right? That's what they tell us, but of course they're eating ice, yogurt. So, but the fact that you can mitigate the damage periodically from leading to an ongoing damage element is a huge advantage in preserving the restorative dentistry. So that's a situation where if the bite changes, we will go in and treat it.
I'll make a comment on the removing torque I found in my practice by using the low-frequency tense. As one of the principles and keys that we've always advocated in our teaching was to relax the muscles physiologically and then be able to find out where the jaw would like to be, where the muscles are neutralized, and then we will then use involuntary tense to find the prematurity, and then make the adjustments accordingly to where the muscles like to do the closing pattern. This way we were able to take the torque out, and as Robert was conveying, that the jaw always wants to function posteriorly. With the Myanmar 10, we're able to find where the muscles want to relax forward, and as the jaw does, you're able to find that the nasal-facing implant oftentimes are entrapping contacts that are distalizing or posterizing the jaw. So what we like to do is at least remove those premature interferences so the jaw doesn't keep drifting back. Take the torque out that way.
Thank you. Question to Dr. Tunks. Are there courses one could take on the skills you showed today?
In short, CAPM does that kind of thing.
2 weeks from now at the Sheraton Hotel.
But, on that specifically, we haven't put together a course on that specifically at this point. We will with time, but then it'll come up in the next course. The CAPM is largely skills-based courses.
So join CAPM and go to the meetings. Is that what you're trying to say? That's what networking is all about. Dr. Bernardo, What do we know about the modification of the tongue muscles with reference to sleep appliances directed in that area regarding, examples would be tongue retaining devices, the Coropian appliance where tongues are directly affected intentionally. Do we know much about how how affecting those muscles is good or bad in sleep therapy? Does that make sense?
Well, with reference to like oral appliance therapy and
Right.
being in the home,
Right.
in the studies that I've been involved in, where we've kind of compared baseline versus follow-up, we found some profound effects in simply in one night when we used appliances that did take tongue positioning and repositioning into account. Comparing tongue retaining devices and appliances that do not take tongue repositioning into consideration. There's been some studies that have looked at it, but overall, a lot of the studies that are out there have only looked at mandibular advancement devices that do not have open interiors. I don't know if someone else wants to comment on that as well.
Anyone else feel comfortable? You're not required to, but if you have anything you want to say.
Here's one thought. I think the group, I do know that as we are advancing the mandible slightly down and forward, you do increase the posterior vertical dimension and increase the oral pharyngeal airway space. Even in anterior combined cases, even though the anterior combined might be seemingly open, but by relaxing the muscle, you see the posterior actually slightly drop, and the anterior is kind of increased, but the jaw does move slightly forward, increasing the oral pharyngeal airway space. So when you set up your appliance, then you can basically help create the proper exclusion, as we've been talking about, I think, for the last few days, to create and remove the torque out of the jaw so the muscles can't calm down. And actually, we found that the patient actually sleeps more restful and has a better nighttime sleep.
Thank you. I've already cleared this with Dr. Tonks. He asked a very complicated question, and I thought I would ask him to phrase it himself because I'm sure he wouldn't do it justice at all. Dr. Tonks.
Dr. Kirstein, I won't go through everything I wrote down, but the crux of it is this. There's at least two pieces of evidence that you gave that would suggest that the mechanism of pain is not likely due to accumulation of lactic acid, particularly in that environment, and much more likely due to nociceptive afferents going to the, affecting the astrocytes and the white cell support at the brain level, which would then be opening up calcium channels, which would be releasing glutamate and lowering the pain threshold in a tonic way through the NMDA. That would suggest that central mechanisms get involved in this, that if you continually bombard with afferents from these ligaments are becoming tender in the periodontal area, and as they begin to bombard the central structures, you start getting a lowering of pain threshold which remains and which generalizes the pain in the area, which recruits the muscles, which are much more likely to go into spasm. Then you get rid of that problem, and the center of force begins to move posteriorly again, but you don't necessarily find yourself back in the same problem because you've broken the central pain feedback loop. And I think it really would be worthwhile in the future, people in the dental industry starting to look at how central pain mechanisms contribute to and complicate dental pain problems.
Well, not that I have studied central pain mechanisms, but it is something I'm sure many of you who are in the pain game have been to lectures where they're talking about things like sympathetic maintained pain and, nociceptive pain. And there is a branch of, I don't think we have it as a specialty, but it would fall into the realm of this kind of a group where they are looking at things just like that, which is what he was asking about. And, the cascade effect of having a chronic irritant creates these changes within the central nervous system that have been well documented, and certainly people are looking at it as far as TMJ pain is concerned. So it is on the horizon. And there are people who actually treat that way, injecting the spinal column using chemicals to try to treat someone with maintained pain. I can't speak to it with any knowledge, but it's certainly being looked at in the field of TMJ and pain.
Anything
comment I'd make is that it isn't just sympathetic pain mechanisms. There are a lot of different kinds of neural pain mechanisms. They include downflow from the midbrain, the sensitization of nociceptors that have been irritated for a period of time, the release of glutamate, the effect of NMDA receptors, and a lot of other things keep going. So I think it really is a fruitful area in the future to start looking at these things.
Thank you. Question to both Drs. Kirstein and Chan. After you finish a case, do you and how do you choose a night appliance?
Honestly, in my practice, I rarely choose a nighttime appliance. Very, very, very rare. We're able to at least neutralize the cases, and most of my orthodontic cases don't have quote-unquote retainers because I believe that the muscles and the type of occlusion we have set up are actually naturally retaining the case. We've had long-term study cases that have shown that the teeth are maintaining themselves in a neutral zone where the muscles, the tongue muscle is neutralized, the masseter muscles are neutralized, the head and neck are maintaining their posture. So therefore, the occlusion and the teeth are maintaining pretty well. In my rehabilitation cases, if there was a patient that had a sense that they would like to have some kind of appliance, I would just make them a normal, just suck down type of appliance or some kind of acrylic stent and just grind it in. I don't go into great extents of doing heavy colonoscopy. I just make it very, very simple. So from that perspective, that's what I do with my particular full mouth reconstruction case. You just keep it very simple. The reconstruction is done the way it's supposed to be. Keep everything neutralized, harmonized, and have happy muscles. So the patient's happy and minimize the amount of things we put in their mouth already.
For me, I try not to make any orthotics in general. That's a rule of mine. So I don't make post-treatment orthosis unless the person demonstrates punching and grinding habits. In these types of patients, which we were talking about today, that persist in their follow-up visits. So they would tell me, I woke up, I knew I was grinding my teeth, or I can tell. It's different, but I can tell. So those people, we, again, don't make anything too sophisticated either. Sometimes it'll be an anterior deprogrammer to wear at night, which keeps their back teeth from engaging in any way, which lessens the ability to push the periodontal ligaments down. And so that's an effective way to limit residual punching and grinding. If it's a prosthetic patient who's a puncher and a grinder, then I might make full coverage acrylic prosthesis like the type Clayton was talking about. And again, giving them anterior distribution. It's a protective materials. But it's not something that I really advocate, as you can probably tell. And it isn't that I don't have failures. I mean, things crack and break. But I don't necessarily, can't say I can attribute that to clenching and grinding as more likely to cyclic overload, which occurs during chewing and eating as well as during clenching and grinding. So my goal, which is a rare goal to have these days, is to not have to make an orthotic. I really don't want to. And I want the patient to live without orthotics. That's one of the things that I've been advocating for a long time, working with digital occlusion. So if I have to do it, it's probably going to be some kind of cushiony soft appliance for a natural tooth patient, or an anterior deprogrammer for a natural tooth patient, or a hard appliance to protect the porcelain in a fancy prosthesis like a glass ceramic reconstruction or something like that.
Okay, thank you. This question appears to be directed to our sleep people from a dentist in Ontario. Given that PSGs are now limited to once in a 12-month cycle, when do you realistically see home sleep appliances being accepted as a valid alternative to PSGs, at least in the province of Ontario? So once
You mean home sleep test?
home sleep study, yes, sorry.
Well, there was a guideline document that was just recently published by a joint committee of the Canadian Sleep Society, Canadian Thoracic Society. I believe Dr. Catherine Ashton-McGregor was actually on the committee as well. So there is a trend towards more and more acceptance of that technology. Even at the recent sleep meeting in Quebec City in September of this year at the World Association of Sleep Medicine, we're seeing increasing uptake in the technology and the acceptance from the general sleep medical community. with the pressure, with the increasing pressure on budgets worldwide on healthcare, and also with the baby boomer demographic, there's increasing pressure throughout North America on the existing paradigm. So what we're seeing is increasing growth, obviously, within the dental sleep community, but also throughout Canada and the U.S., there's increasing acceptance of the technology. So, for example, in the U.S., a lot of the insurance companies are now switching their policies so that in the past, they would not accept home sleep testing, whereas now they're actually not accepting the de facto sending the patient to the sleep laboratory first because of the increasing cost. So a couple of years ago, one of the insurance companies in the U.S. actually came out with a public policy statement. It was Aetna, and they said that they would now require pre-authorization for the sleep laboratory test, but no longer pre-authorization for the home sleep test. So there's been continuing research. Just another article that came out that was published, I received yesterday, and they used the home sleep test and confirmed that there is in fact no difference in outcomes. Now they were measuring CPAP outcomes and the efficacy of doing a home sleep test, and then they had another group doing the laboratory test, and they were using the CPAP therapy. But the key point was that there was no difference in outcomes measures based on whether the testing was done in the lab or in the home. So we're seeing that trend more and more, and I think we're just going to continue to see that paradigm change for a combination of financial pressures and technology that's now here and available.
Dr. Compton, anything you want to add?
I really hope that that will be the outcome. I would think Holter monitors have been sent home with patients forever, and that's just considered quite normal, the appropriate way to do your measurement. And I see no reason why you can't do that with these devices that are now available.
Okay, thank you. And the final question, and it's a long one, so my apologies to the writer. It's directed to Dr. Kirstein. You mentioned a positive feedback loop where molar PDL compression stimulated masseter contraction. This contraction was indicated in pathologic lactate buildup. How is this system different than when we are in basically eating? Should we tell our patients not to chew food?
It's the same mechanism, and it affects only certain people, obviously. You see the people who it affects, they come to your office and they complain about getting tired chewing. So no, we can't tell them not to chew food. We want them to chew food. And actually, protein was shown today to be very helpful in stabilizing insulin levels, and you want them to eat protein 3, 4, 5 times a day, actually. But you can't know who's going to be affected by the molar periodontal ligament contraction mechanism. They appear at your office with complaints of facial pain and headaches. Neuroanatomically, it falls along that pathway that we talked about. But it's in everybody. Every one of us has it. How it's moderated in some of us. For example, if I measure someone who has a 2-second exclusion and they don't exhibit any symptoms, it's because the lactic acid component doesn't build up enough to squeeze out the oxygen in their muscles so they don't feel it, or they don't make as much lactic acid, or the brain has ways of blocking the amount of firing pattern that goes on, efferently. We don't know. We don't know. We cluster it as physiologic tolerance, and it appears that females, Asian and Caucasian, make up the bulk of those that suffer these problems, and so they don't have this tolerance. Why? Nobody knows. Why 9 times more women than men? Nobody knows. So I would never tell them not to chew, but the people that are susceptible to the mechanism, they need it very precisely managed in order to limit the effect it has on their physiology and, of course, their psychology and their quality of life. So I think we've all tried. This is the last thing I would say. We've told patients many times one of the treatment regimens is don't chew hard foods, don't open wide, eat soft foods. Those are palliative measures to control this mechanism. But of course, it doesn't impact it really significantly, because even if you do that, use easy foods to chew, you still have to swallow and push your teeth together. And that goes on 1,000 times a day. So every one of us is always compressing our periodontal ligament. We just don't know who's going to be susceptible. So there isn't a way to tell the patient not to eat. It's better we fix it where we have to, and and monitor where we don't have to fix it.
Very good answer. Hope that satisfies the writer. Well, it's now a little after 5 o'clock. Let me close the meeting by reciting the thing I had to memorize in dental school. May there never develop in me the notion that my education is complete, but give me strength, leisure, and zeal continually to expand my knowledge. Moses Muhammad, 1600 BC. As I look around here, I still see a gentleman from Panama who's going a long distance to get here. We have someone from Vancouver. It's 5:15 on a Saturday. We have more than one profession up here answering questions from you folks. We've had 2 long days of, I think, one of the best bridgings of our 2 professions and expanding our horizons in terms of learning a lot more than, as Mr. McLeod said, I used to just fix those little white things. I'll never go back to that, and I'm stimulated every time I come to hear some more things that I have to learn when I go back. So hopefully you're all going to go home with an excitement about what you've learned this weekend and recharge yourselves, rededicate yourselves. Thank you very much for supporting us, our 5th anniversary. Thank you very much to the speakers who stayed by, and we'll see you next year in a hotel close to here for our 6th annual meeting, dates to be determined. Thank you so much. The meeting is closed.